Why is it a majority from 2, 3, 4?
I think this session is going to be a revision, huh? You already covered pathway, huh?
We covered it in
Yeah, you covered it in studies. So we are going to discuss what you covered text. Because when they are discussed with the spinal cord, they are discussed as structures in the spinal cord. And in the spinal cord, the tracks are related.
Yeah.
So let us start by the way, switch on first and then, yes, Bismillahirrahmanirrahim. Now, we are going to go through the introduction, which is mostly consolidation of what you already know, and then we will discuss sensory modalities, border revision, and then ascending tracts. Now, although the topic of my lecture I called it ascending pathways and then ascending tracts. Just a reminder, pathways versus tracts, you know, huh? Pathways versus tracts. And this is why I start saying when you are talking about the spinal cord, you are talking about tracts. Even if you are talking about the midbrain, in the midbrain you call them tracts, you call air. The instead call them cross, and they are in the brain stem. But pathways include both. Yeah, starting from the beginning to the end, and a pathway, there is a minimum number of neurons in a sensory pathway, ascending pathway, which are three, you know them. The first order, the second order, and the third order. Usually, I said usually and a minimum, which means we could have less, we could have more. Do you know where do we have less neurons? Not
factory.
well, factory, yes.
Only one.
It's one neuron. And then where else? Where else? In the ascending pathway, do we have 2 neuron pathways?
Yeah, and I think it was not Coolidge.
Very important, because half of the ascending pathways, almost half of the ascending pathways,
Is it
are 2
perception?
neuron pathways.
Proprioception?
Yes. Can you
Because it's not, it doesn't relate, it directly ascends from the spinal cord through the dorsal column system and then to gracile and corneate nucleus, directly to the thalamus and the
there are 3 neurons. Good, you remember,
because pain and temperature is it crosses first and then it ascends as the lateral.
Let's focus on 2 neurons. Where do we have 2
I'm comparing
neurons?
you with this.
Where do we have? You said proprioception? Yes. But explain more. The one you mentioned, it is proprioception, but it has got 3 neurons. Cerebellum. Spinal cerebellar pathway. But 2 neurons, because the one go to the thalamus and the one go to the cortex.
Yeah.
No. Do we have proprioception that goes through the thalamus to the cortex?
Yeah, the one.
Which one?
Yeah, through the dorsal column system to gracile and corneate.
Yes.
Then to the
That one is the 3 neurons.
Yeah, this is from lower limb, like a lower limb for gracile and the upper limb for corneate.
That's good.
Yeah.
It's a good.
Yeah.
What about the head and neck?
Head and neck is 2. It's
Why 2?
because there is
You started it. You said proprioception. Now we are discussing, because this is the area which we need to explain more. You know details of the anterolateral system of limb, but now we are discussing the proprioception. Proprioception, you mentioned issues related to posterolateral medial lemniscal pathway and that unit gracile, etc. But that is the 3. What do we call this one? This proprioceptive pathway that follows the posterior column medial lemniscal system. Is it different from the spinocerebellar pathway? They both carry proprioceptive impulses. What is the difference? Very important.
Doctor, is it about the conscious and unconscious?
Yes, thank you very much. The first one with the three neurons is conscious proprioception. You know. With this, you know whether the muscle is contracted or relaxed. You know whether the joint is flexed. You know whether the tendon is stretched or not. You know. This is carried through the posterior column, medial and distal pathway through the thalamus to the cortex, conscious. While spinocerebellar, subconscious. And this subconscious or unconscious, and don't get me to talk about this consciousness again. Is it subconscious or unconscious? Is it subconscious for proprioception or unconscious? Subconscious for proprioception. So,
because you are awake, you are not awake.
Subconscious proprioception is most important, is more important for the control of posture and movement and all of that, because the cerebellum is actually taking care of that, so it needs all the information it can get. So, okay, it's good that we cleared that from the beginning, and we know now that there are that. Okay, I said a minimum of 2, and we now know which pathways have only 2 neurons. But a minimum of 3, I said, a minimum of 3. Can we have more? That's 3.
Yes.
How well? In certain places we have interneuron.
Yeah.
Then the pathway becomes
4.
more really.
Yes.
If we have an interneuron. Now, by the way, why do we have more than 1 neuron? What is the purpose of having a synapse? What is the purpose of having a nucleus in the spinal cord? Why doesn't the axon go straight from the...
And lesions.
Huh?
And lesions.
Reflexes?
Functionally, not
Because
clinically.
it's faster to go through the spinal cord than the...
Interruption will delay. And in fact, the nuclei in the spinal cord and in the brain stem are called relay stations. What does that mean?
Because multiple other neurons relate one.
Okay. Okay, some sort of integration in a way, yes. What is the purpose of that?
Because all information regarding one thing should be.
You need to remember words that have specific meaning and it makes life easy. So, relay stations are for the purpose of modulation. If the impulse goes straight from the cell body in the dorsal root ganglion or whatever, cranial nerve nucleus, straight to the cortex, you don't have the chance of changing it, increasing it, reducing it, affected by cross-talking from other axons coming to that relay station. So the purpose of modulation, and you had pain and pain inhibition and all of that. Increasing the tone, reducing the tone, inhibitory effects, stimulatory effects. Where do these actions take place? At relay stations. So second order neurons are relay neurons where modulation can take place. Okay, this is regarding speaking the pathways. Another reminder. Okay, we already done with that. A minimum of 3, a series of model-specific neurons connected by synapses, and now we know why. Now, most have at least 3 neurons, first, second, and third order neurons. The receptors can be the first order neuron or can be an additional receptor neuron. Isn't it? It's still that. Receptors are either modified referral processes of neurons or first order neurons, or modified cells that become receptor neurons. Give me examples of receptor neurons.
Hair cells.
The hair cells in the ears.
And the rods and cones.
The rods and cones of the retina. And so you know, there are some, yes, but there are some cells which are modified to become receptor neurons, but are not part of the three order neurons. They are an additional. And this is another place where we can have more than three. We have a receptor neuron, then three first order, second order, third order. Okay. Or modified neuronal or epithelial cells connected to terminal axonal endings of first order neurons. These are the examples, you all know them, you've studied them many times in the skin. And in the skin we have the different types, the Meissner, the Pacinian, the Ruffini, even the hair cells, the hairs, the bulb is related to free nerve endings, Krauss, the Merkel and all of those in the skin. And of course you know they are different in the glabrous and hairy skin. There are 5 here but there are 6 there, and so on. You know all about that, different mechanoreceptors. Some of them are exterior receptors but not mechano, and some mechano for proprioception, and so on. You know all that, just a reminder. In addition, we have some specialized ones in the muscles, in the tendons, and in the joints. And these are for proprioception. And you know them, and this is where the connection with the muscle spindle and the Golgi tendon organ. Okay? And this is the Golgi tendon organ, and this is the reflex arc generated by the tendon organ and the muscle spindles. Now, these are the 4 types of joint receptors. They are similar to the ones in the skin, the Ruffini, the Pacinian, and the Golgi tendon, and the type 4, which is the free nerve. Similar, but they are specialized joint receptors. One of them is for pain, the others are for proprioception. Now, these are the receptors. Now, the modalities you already know them, we already now mentioned them. So, what sensory system transmit and analyze what? General sensation. We define general sensation, the term, meaning it doesn't have a very specialized organ for it. So, they are general sensations. And if they are coming from the body parts and the head and neck, the limbs, body walls, head and neck, they are somatosensory or somatosensation. Somato-general sensation. If they come from the viscera, they are general visceral sensation. General sensation. So we have general sensations, external and internal. External and internal. In the joint, they are internal, external. In the visceral, they are internal. On the skin, of course, they are external. So external and internal locations in the body, and these include. I'm making this list because of the different terminologies used. Let us finish with this. The first one, crude or light touch, or non-discriminate. That's what you know all about. You feel that something is touching you, or you are touching something, but you cannot tell what is it, what are the characteristics. But there is touch. It's called light or crude touch, or non-discriminate touch. Then we have discriminate. But I need to discuss it a little bit because you already started history taking and physical examination and all. So, what is discriminative touch? When you examine a patient and you would like to know whether there is a problem in discriminative touch,
You get them an object.
there is this 2-point discrimination.
Yeah.
Okay. Okay. There is just discrimination. There is 2-point discrimination. Are these 2 points or 1 point and so on? So, what is this related to what? What is it related to? Is it related to the receptors, to the pathway, or to the cortical function?
Is it related to the pathway?
Yeah, I think so.
Let us listen to what she said. What about receptors?
Because multiple receptors cover different grounds, so there will be an area where multiple receptors cover.
Yes?
And so when you have two different points, whether or not both are being caught by different receptors are the same.
So you mean the concentration of the receptors. If there are only very few, then you will not be able to do this too, because maybe you touch 2 points where if they are too close, then 2 point discrimination is very precise. So it is, to start with, related to the intensity or the concentration of the receptors, preference speed. Then, centrally speaking, perception at the level of the cortex, beyond the thalamus, So when you are taking a patient on discriminative touch, 2-point discrimination, first of all you need to identify which area you are taking, because if you are taking the back, you expect 2 points to be widely apart, to be discriminated. Because it depends on the concentration. So you need to be aware of that. But also we are taking higher function. We are not taking touch in the pathway. Okay? Is this clear? Because the second one is also important and it relates to what are we taking. You know what stereognosis means?
Yes.
Yes?
Ability to identify objects when your eyes are closed.
Close. So what sort of sensation?
Discriminative touch, right?
It includes discriminative touch.
You combine the
And proprioception.
combined
Which is a part. It's a combined between discriminative, it's a combination between discriminative touch and proprioception. And so, it's a function of what? Receptor? If somebody has got a problem in stereognosis, you know what graphesthesia is?
yes.
Yes, when you draw something on the skin, this is a circle, this is a K, you draw a K. So, graphesthesia, stereognosis, and these things, are they related to? Yes, of course, related to. You need to have both intact discriminative touch and intact proprioception, but at the same time, you must have an intact higher function. When we say higher function, what area are we talking
Sensory.
about? Huh? Is it the primary or the secondary? Which is 5 and 7. Integrative association.
Secondary.
If the secondary is damaged, then you will not have this stereo, because this is where it happens. And of course, if you have damage anywhere below that, you will not have stereo, because the information is not reaching this higher function. But you need to start looking at it from top to bottom. First, you look at MRIs, you look at X-rays and everything, and check that area. Nothing there, then you go down. If there is a problem in stereo. So why are we discussing this? Because we need to know what good is tactile sensation. This discriminative touch. But individually discriminative touch is used to identify whether the surface is rough or smooth. Discriminative touch as touch. Then it is also part of stereo. It's complementary to proprioception for stereo. This is tactile sensation, means this discriminative touch. Then we have some important sensations, often ignored: vibration, tickle, and itch. Are these important?
Yes.
What for?
It's also part of proprioception.
What are they important for? I know proprioception, proper proprioception, humor, muscle, pressure, tendon, joint, these are important for movement and position. But what about tickle and itch?
something.
So it could be a
Yes.
sign for
For danger,
Huh?
danger or something.
I guess, thank you very much. Warning system. It's a warning system. It's a warning system. There is something going on there. There is a chemical, an abnormal chemical there. There are some microbes in my trachea. Then there is tickle, and then reflexively I sneeze. Huh? So very important opening group. Vibration, tickle, and itch. And then of course we have thermal. We have no C-section. Now, why no C-section? Why do we have pain, by the way? What good is pain?
So it is a warning system.
It's a warning system. It's a warning. But warning you about what?
There is something wrong in your body.
Wrong? How wrong?
Yeah, damage.
There is tissue damage or impending tissue damage. Potential tissue damage. Beware. Do something. Something is going on. If you don't deal with it, there will be tissue damage. So it's a warning system. Warns you that there is tissue damage already there, or there is impending tissue damage, you need to do something. Now I need to discuss colic. What is colic?
Severe pain.
Yes, it is severe pain, but it is because of its path. Well, what is wrong with this path? We need contraction of muscles.
No, this is when there is no, for example,
There's no control.
digestion, then
It could lead to ischemia sometimes.
or if there's a
Yes.
block also. If there's a block, there is a reflex contraction that happens in the distal.
What I said, contraction is needed. We need
Yes.
muscle
Loss of
contraction.
control
What's
and
wrong
then
with
the-
contraction?
It's a loss of control in the contraction.
Yes, contraction is supposed to be contract then relax.
Yes, but there's no relief.
When there is no relaxation, there is ischemia because the blood vessels are inside the muscle itself. When the muscle continues to contract without relaxing, it is obstructing its own blood supply. So there is ischemia. Ischemia means beware. If this continues, tissue damage. Because the major cause of tissue damage is ischemia. Ischemia. So, colic is one type of pain. Pain in general is a warning system, but it is warning you that there is tissue damage or there might be tissue damage if what is happening continues to happen. And then lastly, you already mentioned proprioception, but I need to concentrate. Proprioception is position and movement. Position and movement. Okay, this was a long introduction, but it's important. The pathways, as you know, are we have the central process of the first order neuron and the second order neurons in the spinal cord and brain stem, of course, and then the cerebral neurons make the sensory pathways or system. Now, they convey the sensations to the somatosensory area, the first somatosensory area, somatic area, area 3, 1 and 3, and then some sensory pathways convey information to the cerebellum. You know them. They go directly to the cerebellum. Now, there are discrete pathways, you already know them, it's a revision. We have the anterolateral system, and it's called the anterolateral system because we have anterior and lateral. And are these anterior and lateral tracts axons of first order neurons or axons of second order?
Second one.
Second order. You know them in the substantia gelatinosa, it's a relay station, it's contralateral, and all of them. One important piece of information. The first order neurons enter into the spinal cord. And then they cross to the other side. Where do they cross? Whereabouts?
So they enter from the posterior horn of the spinal cord and then they cross to the anterior horn on the opposite side.
Okay? But whereabouts? يعني عندنا two horns, they enter the horn, then cross between horns.
No, down central.
Where down?
In front of the
Where?
central canal.
Yes. Very close to the central canal. There is a central canal, and then there is a strip of grey matter anterior to the central canal. It is called the grey commission. And then there is a very deep anterior fissure, anterior longitudinal fissure in the spinal cord, very deep. It goes in very close to the central canal of the spinal cord, separated. This fissure is separated from the central canal by two commissions, a grey one and a white one. They cross in the white commission between the grey commission and this sulcus or fissure. Why am I concentrating on this? Because there is a clinical condition called syringomyelia. In syringomyelia, there is dilatation of the central canal, usually at the upper end of the central canal of the spinal cord. And when there is dilatation, as we mentioned yesterday or in the blood supply lecture, if there is any compression by anything, it will lead to compression of the blood vessel, then we have ischemia.
Yeah.
Now this pharynx is going to damage both the grey and the white commissions. So these fibers crossing, whether they cross in the white commission or in the grey commission, might be damaged in syringomyelia. So you will have symptoms related to that. So you need to know that the first order neurons, first of all, they cross from the dorsal horn anteriorly, and they cross in the grey or white commissions anterior to the central canal, and they go to where?
They go the thyroid neuron and the thalamus.
These ones which cross, what are they? Are they second order neurons or first order neurons? Second order, because they come from this gelatinosa of the ipsilateral side, but they go to the other side. When they cross, they either cross to the anterior column or to the lateral column.
Yes.
If they cross to the anterior column, they collect and make the anterior spinothalamic tract or the lateral spinothalamic tract. Both of them are called the anterolateral system. A reminder. What is the other name for column? Funiculus. What is the other name for bundle? Fasciculus. So they cross to the anterior column or the anterior funiculus, or the lateral column or the lateral funiculus, because you find that in histology. This is the anterolateral system. And they go to the thalamus, because they are spinothalamic tracts, and they are the second order neurons, or the absence of the second order neurons. Then we have the trigeminothalamic part. Of course, you remember, we have how many sensory ganglia? How many sensory ganglia?
Trigeminal ganglia.
Trigeminal, I mean trigeminal.
Yes.
How many trigeminal?
How many, nuclei. Nuclei. 3 nuclei.
Yes.
The main, the spinal, and the mesencephalous. From this, we have a tract. And we have, do they cross to the other side, the tract? Do the fibers from this nuclei ascend ipsilaterally, or they cross and ascend contralaterally? Do we have something called trigeminal lemniscus?
Yes.
Then they cross. They cross the system. These are the trigeminothalamic pathways or tracts. Then we have the posterior medial lemniscal pathways or tracts. you say posterior medial lemniscal, it's a pathway. Because we have posterior colon tract, and then the medial lemniscal tract. You know about it. So it's a pathway. So we have posterior colon medial lemniscal pathways, and you know, tell me the story quickly, because it's a revision. The first order neurons are found in the dorsal root ganglion, the axons enter the spinal cord and through the, and then what? They enter through the dorsal root.
Yeah.
And then, do they synapse?
No.
No, they ascend as dorsal column system to gracile and cuneate, and then as the internal arcuate system, they cross to the other side, become median lemniscus.
Okay, come on. A little bit of detail. Cuneate and gracile. If I have compression of the spinal cord in the thoracic leaf from outside,
Yes.
what will I be damaging?
Cuneate.
From
From outside.
Yes, okay?
Cuneate is from outside and gracile is from the inside.
Okay. You get the idea, huh?
Yes.
Because they are coming from the lower limbs and pelvis and all of that, and they are always on the outside. Okay. When the spinal cord goes up and the cuneate part of the posterior column enters, they are usually on the inside and they ascend. So we have two fasciculi. Two fasciculi. It is one funiculus, which is called the posterior column. Posterior column, but it is divided or separated into two fasciculi. The one on the outside is called the fasciculus gracilis, and the one on the inside is the fasciculus cuneatus. Two fasciculi, two bundles in the same funiculus, in the same column. This is called the posterior column tracts. And they are first order neurons, axons of first order neurons. When they reach the medulla, what do we have there?
Wait, but the axons of first order, not second order?
You tell me. From first order or second order? The posterior column.
Posterior columns. Oh, no, posterior column system, yes, it is first order.
Yeah, posterior column
Because
tracts.
they don't.
The tracts are first order
Yeah.
neurons.
And they ascend to gracile cuneate, and then the median.
What is the gracile and cuneate? Gracile and cuneate what?
Posterior.
Nuclei.
Yeah,
Nuclei. And they are medullary nuclei.
yes.
They are not spinal cord
Spinal cord.
nuclei. And these are the relay stations. Yeah, these are the relay. This is where modulation takes place.
Yeah.
Then the axons from there,
They
cross.
cross. Becoming
the medial
lemniscus.
lemniscus. The medial lemniscus.
Yeah.
And then they ascend on the other side contralaterally as what? What is the name of? It's called the medial lemniscus, huh?
Yeah.
But inside we have cuniothalamic
And
gracile tracts. The tracts within the medial. But this is called the medial lemniscus. It goes to the third order neurons in the thalamus. By the way, where about in the thalamus?
posterior, ventral,
Ventroposterolateral
ventral,
and ventroposterior for the trigeminothalamic part.
Yes.
Okay. What about the spinocerebellar pathways? Well, I'm supposed to make the list, then go to the PowerPoint, but we are fine. We are fine. Spinocerebellar pathways. What are they?
There are dorsal and there are ventral.
The anterior and posterior or ventral and dorsal. And yellow, where do they come from?
The ventral gives information from the.
No, you say the absence of the first order neurons enter the spinal cord. Then what? Do they relate somewhere? Yes, they do. Where?
Anterior.
Anterior lateral for reflex. عندنا second order neuron. Where are the second order neurons? قلنا two neurons. مش كده؟ مش قلنا spinal cerebellar subconscious؟ Where are the second order neurons of the spinal?
Main sensory
Nuclear? Nuclear of the spinal cord?
Yeah.
Nuclear of the spinal. Which nuclear? And when I talk about anterolateral system, you very quickly tell me substantia gelatinosa.
Because we didn't take the pathway of the spinal cerebellum.
Okay. Then let us go to the pictures. Then we need the pictures. It's not the review. Okay then. We have something additional. We will discuss this when we get the pictures. But we have something called uniocerebellar. Because this we need a combination between conscious and subconscious. Because posterior column medial lemniscal pathway is for subconscious proprioception. But we need to connect it with the subconscious proprioception. So through this additional tract, it goes to cerebellum from the uniatus. So we have nucleus uniatus giving some of these neurons will go to the cerebellum directly, and it is called the uniocerebellum. There are some related from the bulb, from the medulla. We will list them, but we will not discuss them, but you need to know. Because I think you already discussed the cerebellar function. We have vestibulocerebellar, and we have olivocerebellar from the inferior olive, and we have reticular from the reticular formation, and we have trigeminocerebellar. And these combine the sensory, they combine the sensory conscious sensation with subconscious sensation, and they combine motor function with the cerebellum. So they are considered ascending pathways because they ascend from the spinal medulla, from the medulla to the cerebellum. These are additional bulbocerebellar. They come from the bulb to the cerebellum to complete this function of the cerebellum. So now we already covered the anterolateral system, but here we just link it to the type of sensation. You already. What type of sensation is carried through the anterolateral system?
Pain and
Pain, temperature, and
pressure. And go up, touch.
crude touch, light touch, pressure sensation. Okay, so these are through this. Of course, the three neurons, first order in the pseudo-unipolar, 10 minutes, no problem. After 10 minutes, we move on. Of course, you know it in the dorsal root ganglion, dorsal posterior cord of the spinal cord. We already mentioned that. The second order neuron and the substantia gelatinosa decussate ascends as the direct pathways of the anterolateral system. We already mentioned that in the contralateral thalamus, with collaterals to the reticular formation. In the indirect pathway, and this is spino-reticular, we go to the reticular formation. To synapse in the reticular formation, sending some collaterals to the thalamus. This is called the indirect pathway. You don't need to worry about it too much. And then we have the spinomesencephalic, also spinotectal, spinothalamic fibers to synapse in several brainstem nuclei. These are additional connections of this anterolateral system. Now, hypothalamus. Hypothalamic connections are important because they relate sensory information to emotions. The emotional appreciation of sensory experiences are through connections to the hypothalamus. There are projections to the hypothalamus. These are important, and they are related to autonomic responses and autonomic reflexes. When people have pain, you find that they have grimaces in their face, and these are emotional responses to pain through this hypothalamic autonomy. One question, one not easy question, not difficult, but easy. Are the muscles of facial expression supplied by voluntary nerves or involuntary nerves or both?
Both.
You to mean they are striated muscles when they are supplied with sympathetic fibers, the muscles of facial expression.
Doctor, remember before when you mentioned that facial nerve is considered special visceral?
A special visceral because of development.
Okay. So
But this is a different, a
that's
slightly different question. Yes, research proved that these the muscles of facial expression are supplied mainly by the facial nerve, which are special visceral efferent. But we have some general visceral efferent fibers coming from sympathetic preganglionic, postganglionic neurons supplying the cells. How did they discover this? They had people with upper motor neuron lesions, damaging and facial nerve nuclei. And then they examined patients with emotional stimuli. And then they discovered that the muscles of facial expressions react. How do they react? The nerve is damaged. Yes, through sympathetic fibers, reaching them through this hypothalamic pathway, because the stimulus goes to the hypothalamus, from the hypothalamus through the sympathetic system, contractions in the muscles of facial expression, there is expression of emotion. So I just mentioned this to consolidate this important point about the relationship between the anterolateral system and the hypothalamus. Now, the third order neurons, these are the first order neurons, dorsal root ganglion. Some of them go directly, and some of them cross to the other side. You see, and this is the pathway in detail. Cross to the other side, and these are the connections I mentioned at the end, with the reticular formation, with the hypothalamus, and then the third order neuron to the thalamus. And here, where exactly? Remember when we discussed the thalamus, we said the intralaminar nucleus is important. It receives collaterals from everywhere. So intralaminar, in addition to the ventral posterolaminar nuclei in the thalamus, but also the reticular formation, the collaterals to the reticular formation. So these are anterolateral system. We want to. This is where this is a somatotopy. Somatotopy. The leg area on the other side, and then we have the leg and trunk. We have the arm, the face, and by the way, the face and head, the representation in the cortex is a very large area, and the tongue and thumb have very large areas in representation there, but including the pharynx and larynx and everything. This is the primary motor, and this is the primary sensory areas. This is where, and this is to show you how big is the representation. The lips, by the way, have tactile sensation. Tactile sensation feel the enamel and the lips. Sensitive, discriminative. This is more detailed, exact location of each sensory experience. Now, the posterior column, which are for subconscious proprioception, for sensory proprioception. Proprioceptive and discriminative touch information, and you know it, yeah? Proprioception plus discriminative touch in the posterior column. Central processes of the first order, they ascend, they do not synapse, they ascend directly to as the tractus cuneatus and the tractus gracilis. Now, reflex actions mainly. Now, the posterior column lemniscal from the dorsal root ganglion, ascending and descending branches. Do we have a name for those? When they say ascending and descending, what do they mean? Some of the fibers actually descend to make connections. So we have some fibers going up and some fibers going down. So the ascending and descending together, they call it Lisuar's tract if you pass across it. You pass across it in the stone. So it's right, the fibers going up and down and descending branches. Now they form the dorsal column pathways, gracilis and cuneatus. مش كده؟ Now in the medulla, in the nucleus, in the ipsilateral, so same side, and nucleus, cuneatus, and gracilis, and then the fibers of these second order neurons deposit and cross to the other side, making the medial lemniscus. Now the third order neurons are in the thalamus, similar, but these are those, the dorsal column, and this is the cuneatus and the gracilis. And this is a description of the pathway, the ascend, nucleus, gracilis, and cuneatus cross to the other side to the thalamus. From the thalamus to the cortex. Now, most of the proprioceptive information are in fact subconscious. And they're transmitted directly to the cerebellum, and it's a two neurons pathway. Now, they process subconscious proprioception of muscles, tendons, and joints. And there are two neurons pathway. So we have, now you already know very well, the spinal, the dorsal and ventral, or the anterior and posterior spinocerebellar tracts in the spine. And the pathway, two neurons. But
we didn't take spinocerebellar.
huh?
We didn't take the pathway of the spinocerebellar.
You already know, I'm going to tell them in the next slide. Yeah. But I wanted to mention that there are not only two. I said you already know two. The dorsal and but maybe you have not heard about the cuneo-cerebellar and the rostral cerebellar. These are important because they combine pathways or tracts from the upper limb and pedal together. In addition to the cuneatus, they have some tracts from the cuneate nucleus and the trigeminal nerve, making one of them is specialized only cuneatus, and one of them a combination is called the rostral. So we have an additional two tracts. They make the pathways. They make these subconscious pathways. So instead of having two, you have four. The dorsal, the cuneo, not now. Not a new meeting?
Yes.
Check. Yeah. This is a cuneo from the dorsal root ganglion. Accessory, it's not the cuneatus, it's an additional cuneate nucleus. Then in the ipsilateral anterior lobe of the cerebellum. So this is an additional one. Now look at the rostral from the dorsal horn and then termination in the cerebellum. These two are additional to the ventral and dorsal. Now, where about in the dorsal horn? You have them, of course, in the dorsal root ganglia, and then they go to the dorsal horn. Do you know about the dorsal nucleus of Clark? What is this?
We only mentioned that in certain parts of the spinal cord we have an additional Clark's.
You only know the substantia gelatinosa?
Yeah, and the main sensory nucleus in the spinal cord.
In the spinal cord, yes.
We have to, we know that there's substantial gelatinous and the main sensory nucleus.
Doctor, was it in Lamina 7?
Huh?
Was it in Lamina 7?
Yes.
Yeah, it is in Lamina 7 in certain parts of the spinal cord, not all.
Related to what? Let us write it on a sign. Let us at the moment say spinocerebellar, the second order neuron are found in the dorsal root, the dorsal horn. Whereabouts? Can you take it for me, please? And then the second order neurons go directly to the cerebellum. And by the way, where about in the cerebellum? Is it the vermis and the surrounding area, or is it the vestibulocochlear nodule, or is it the larger part of the
vermis and the intermediate.
Yeah.
because that's called spinal
Yeah, spinal
cerebellum.
cerebellum.
They go to the spinal cerebellum. Vermis of the cerebellum and the surrounding area. Look at this diagram very carefully. The fibers of the second order neurons cross to the other side. They ascend, then they cross back.
So they're epsilon.
So they are, functionally speaking, they are ipsilateral. The tract is contralateral. The tract is contralateral, but functionally they start on this side and they end on the same side. While the ones of the head and neck, they are ipsilateral. Head and part of the upper limb, ipsilateral, and they go directly. These ones form the rostral spinocerebellar tract. I think we are done. We don't need to go into the details. We don't need. You can read this because I want to finish this presentation. Thank you very much.